Welcome back to episode 10 of the Rehab Exercise and Sports Therapy Podcast, sponsored by University Orthopedics and edited by Marcom and Nancy Krause. I'm happy today to be joined by Dr. Julie Burland from University of Connecticut. I had the opportunity to hear Dr. Burland speak on an ACL study day course, and she was excellent. And I feel that we've been fortunate enough, Julie, in recent episodes to have Dr. Dave Sherman from Northeastern discuss some AMI topics. And we had our last episode, we had Dr. Kate Jochimson from MGH, who talked about kind of chronic pain and some psychological related issues with hip pain. So I feel like your stuff hopefully is going to tie together perfectly and piggyback on that. But if you could, Dr. Bernal, I'll let you give a little bio about your role right now and some of your research interests.
Yeah, so to give you a little bit of background on myself, I got my undergraduate degree in athletic training at the University of Connecticut, or UConn, as we all call it. I ended up going to the University of Kentucky to get my master's in athletic training. So I worked clinically in athletic training for several years. I worked with the men's and women's tennis teams at Kentucky, as well as the cheer teams, which was very interesting and very stressful because there's a lot going on there.
Yeah, and it's high level there, right? I mean, that's like scholarship level, right?
Yeah. They're great. They have a lot of championships. After I got my master's, I was like, I'm never doing research again, and I ended up going and working at Connecticut Children's Medical Center, like in an athletic training residency, where I ended up being exposed to research again. And I was like, oh, maybe I feel differently. And I did. I went back to UConn for my PhD in exercise science, and then did a postdoc during the COVID years at Spalding National Running Center and Brigham and Women's up in Boston, where I learned some additional like biomechanical modeling from Dr. Irene Davis and some cartilage related stuff that I've been actually working on at UConn with Dr. Christian Latterman. So that's been kind of my journey. I still am active in the, clinical athletic training program at UConn. I have interactions with the students, and I teach in the undergraduate exercise science program, a biomechanics course. Yes, I started at UConn and came back to UConn.
Yeah, okay.
Multiple times.
And March is always an exciting time to be at UConn, right? With basketball stuff going on, I'm sure, right?
So now I'm back at UConn as an assistant research professor in kinesiology, and I serve as the director of research for the UConn Institute for Sports Medicine, which bridges the Storrs campus and UConn Health and helping to promote, healthy athletes, active persons across like the spectrum of their life.
Yeah. All right, cool. Excellent. Well, thanks again for joining today. I wanted to kind of focus a little bit on some of your earlier research that kind of focused on this learned helplessness concept. I think I mentioned briefly on one of our last episodes, we had Kate Jochimson, who tied together some of the psychological manifestations with things like kinesiophobia, pain catastrophizing, self-efficacy. And I feel like your research is kind of like a composite, or that whole learned helplessness concept is kind of a composite of a lot of those concepts. And in reading some of your work, it looks like this is not a new thing, learned helplessness, right? We see this across like different species and kind of manifests in different forms in humans. So if you could maybe just give us kind of like an operational definition about learned helplessness.
Yeah, so definitely not a new concept. This was proposed back in like the 70s in an animal model specifically, where the animals were essentially exposed to like an uncontrollable stimulus, and they weren't able to escape this stimulus. And so they developed these like learned helplessness behaviors where they just kind of stopped trying to escape these types of stimuli. There were similar models as well of that learned helplessness and learned non-use, where following like neural injuries, such as stroke or traumatic brain injuries, the evidence essentially saw that people stopped using their limbs, even though they had potentially the motor capacity to do so. And so the thought with, us with ACL reconstruction, for a long time, we've studied the effects of neural inhibition. Dr. Sherman did a great job talking about arthrogenic muscle inhibition. But I don't think a lot of people outside of like the scope of ACL researchers really think of like ACL injury as like a neural injury. But we can see clearly through many published, works that there is some sort of nervous system disruption that occurs in these populations. And so during my dissertation work with the Dr. Lindsay and Dr. Adam Lepley, was really kind of taking that learned helplessness, learned non-use kind of phenomenon and applying it to that ACL population, and seeing whether that kind of we saw those potential changes in that musculoskeletal cohort versus the true neural, patient population.
Okay. All right, awesome. Speaking of that, I think Dustin Grooms and Meredith Chabu, I think you've collaborated at some point with either of them, right? Have done a lot of work as far as the neurocognitive aspect and some of the changes that happen at a brain level. But can you tell us, we have AMI, we have the changes, AMI I consider like kind of like a bottom up concept, right? Where you're seeing like influence or limitations in afferent input from the knee, and then we have kind of the interplay of both of those from a top down level. How do you feel like we see that manifest neurologically with the kind of both factors, AMI and some of the psychological aspects playing off of each other?
Yeah, I think that's a good question. It's a loaded question, right? There's a lot of parts. No, in a good way, right? There's a lot of parts to it. But I feel like for me, like when I think about learned helplessness or that learned like disuse or non-use, I feel like what the like kind of take home messages is that like that develops in response to or in the presence of some sort of neural impairment, right? So going back to like how we kind of propose that learned helplessness might manifest in an ACL population, right, after that knee injury is that someone is sustaining a knee injury, right? They have, or we know they're going to have some level of muscle inhibition just from, injury, from surgery, from those lost mechanoreceptors, that altered, afferent input. What we kind of proposed was that those initial changes and those early changes and feelings of, essentially not being able to utilize their injured limb appropriately, not being able to contract the muscle well, not being able to move well, in addition to that early phase of rehab where a lot of things are really uncontrollable, there's really nothing in their control, that those kind of components would come together to cause that kind of psychological learned helplessness development, right? That those inability to contract your muscle appropriately, move your body, and those feelings of uncontrollability could promote those feelings of helplessness. The other kind of way that we proposed helplessness might arise, early in our theoretical model is through protracted changes in neural changes. So, like we know those early arthrogenic muscle inhibition changes happen. We see, earlier-ish spinal reflexive changes, but there are literature to support that, 2+ years out, right, individuals still have reduced corticospinal excitability or the ability of, our brain to contract our quad appropriately. And so that was another kind of way, like if there's these protracted changes, are these actually causing whole level brain changes that are going to influence these helpless behaviors? So I think like going back to your question of, can you kind of parse it out? I feel like because it's, because we're thinking of it in the frame of being, or developing in response to the neural impairments, I wouldn't necessarily think that, you could parse it out in the sense that if you measure neural inhibition, and again, like Dr. Sherman talked about, the ways that we're going to do that are very sophisticated and not necessarily clinically applicable.
Right, sure.
And so in my thought, like you can easily kind of measure or observe helpless behaviors with, just clinically looking at and dealing with your patients, right? You're able to kind of, look at how they're moving. You can tell if they're really offloading, hesitant to do things. And again, this is going to vary throughout the different phases of rehab. But we also can actually look at subjective measures of learned helplessness in the clinic, and those are free patient reported outcome measures that you could essentially collect to see whether or not people were feeling helpless. And I think like if you kind of notice, hey, our functional tasks or, the things that they're, trying to do during rehab, if those are, uh, impaired or we see a lot of deficits in those and we see them kind of presenting with some of these more like helpless types behavior, even if it's just fear or kinesiophobia or pain catastrophizing, I think that kind of gives a clinician a little bit of like okay, let's maybe look into this further to see if there's something going on relative to like more of these helpless type or learned non-use behaviors.
Yeah. All right. Perfect. So in your response, you segued perfectly into my next questions and set me up. So, and I'm going to ask a two-part question before my
Sure.
ADHD kicks in,
Yeah.
and I get, distracted. So, the first question was, you mentioned the patient-reported outcome measures. So traditionally, I think I don't want to assume that it's a universally held truth, but like ACL/RSI and TAMP scale kinesiophobia are two like main constructs that we use to try to tease some of that out. Are those, I guess I'll ask you, do you perceive, are those the best constructs? Is there something else you feel like should be included in that kind of screening cocktail, for lack of a better analogy? And then I get my next question based off of that is, how often do you administer them and maybe what are the critical time points?
Yeah, so I think that's a good question. I mean, I love the Tampa scale for kinesiophobia. I almost said kinesiology, the
Yeah.
TSK. Just because it gets really at that fear of re-injury, a fear of pain-related movement, and we know that that's a really strong predictor of, not returning to sport or not being able to, do the functional outcomes that you want to do
Right.
down the road. I'm also partial to the ACL return to sport after injury scale because I actually implemented that scale longitudinally when I was at CCMC, the Children's Hospital, and we evaluated, we looked at essentially those scores pre-surgery, 3 months and 6 months, and it really was helpful to say, like, people early on who weren't feeling, I mean, obviously you're not ready to return to sport pre-surgery, but individuals who had lower scores pre-surgery ended up actually taking longer to return to play and had worse outcomes. And so I felt that was really helpful, and it's applicable, obviously, to a lot of the patients that we see post ACL reconstruction. Um, obviously there's specific learned helplessness scales if like you're truly looking to like delve into that. I do think that, the common ones we see, the TSK, the ACL, RSI, I mean, even the fear avoidance belief questionnaire get at kind of some of those constructs. They don't necessarily measure helplessness specifically, but they can kind of flag a patient of, hey, this person's really struggling with some of these factors. And I know that there, Shelby Baez and Kate Jacobson did publish a recent, 2 years, 2023 seems recent, but it's almost
I hear
2020, article on like other psychologically informed outcomes that like you could use in sport injury specifically. But I think the ones that you mentioned are really the ones that I would go to when we're looking at like those fear and readiness to return to sport after ACL injury. From a time standpoint, administration, I would think, like, again, we don't want to burden our patients with a lot of clinical scales. I get it. There's not a lot of time. Generally, I would think about like the timing of like when we have big rehab transitions, right? So like pre-surgery, obviously we're not going to get baseline like pre-injury, outcomes on these folks, but I would suggest maybe getting a pre-surgery if possible. And then between 3 and 4 months when they start to initiate that running and those, more functional tasks. And then, obviously we have kind of transitioned from a 6-month kind of return to play time point to more of that 9 to 12 month based on, factors related to re-injury risk, et cetera. And so I think anywhere from 6 months to 9 months or at the time of return to play would be like the most beneficial, especially because at that time when they're transitioning into sport specific activities, that's when they're really going to be feeling those, potential fear of re-injury, fear of pain with related, sport specific movements or that readiness, factor. So I think that those would be important time points for clinicians specifically.
Okay. So I don't want to infer too much from your answer. I mean, I think I can, but the learned helplessness you mentioned kind of early identification, how soon would it typically manifest? Like, is this something post-op day one?
Yeah.
You're seeing that apprehension, when you're taking the brace off and you ask them to like unwrap the dressing and they're like terrified, I mean, so tell me like how soon does it manifest, I guess? And like from an intervention standpoint, like when is it kind of most best remediated or when can we have the biggest impact, I guess, maybe?
Yeah. So I think that we still don't necessarily know the answer to that because there hasn't been too many studies on too many longitudinal studies on learned helplessness in an ACL population, right?
Yeah.
From some of our proposed work, we thought that it might manifest during that time when those neuroplastic changes were occurring, so somewhere between 3 and 6 months. But
Okay.
in our small case series that we did in like 10 people, I think it was 7 to 10 people. We actually saw that there were, people reporting greater learned helplessness actually like during the pre-surgery time point.
Oh, wow.
And so, again, I'm not saying those patients had learned helplessness, but they were reporting greater perceived helplessness. So I think,
Yeah.
from kind of the summation of the work that I've done, and I have plans to look further into that. But I think that when we have significant nervous system disruption, right, I think that can kind of correlate with when we could start to see potential helplessness symptoms, presentations that non-use develop. And so from like a high level overview, I'm really going to think that this is probably somewhere between like surgery and like that 3 months. And again, similar to how that arthrogenic muscle inhibition presents, we know that there's that early, weakness inhibition. It does tend to get better as we move through rehab. Around 3 months, right, they start doing more functional tasks. They get their muscle strength back generally. But still somewhere in there, we see those continued neural deficits. So I think that if patients have a hard time with like the motor tasks, I can see that around this time would be a time when the helplessness behaviors might manifest, where they're not able to, do tasks well. Maybe they're not able to do like double leg, single leg squats appropriately. And so it frustrates them and it makes them feel like, oh, I've been in rehab for 3 months. Like, why can't I do these common tasks, right? And then when you think about how they might anticipate doing sport specific tasks, like they're going to feel like they're in in an uncontrollable situation, even though they've been in rehab and have been doing all the right things, if you will.
Sure.
And so I think that kind of time point it is where we're probably going to see most manifestations of it.
Okay.
We did have some, again, very preliminary research in patients that were very chronic. And again, I think that goes to that protracted kind of arm of our theory of like,
Yeah.
in patients who just have continued inhibition, continued neural deficits, like we're probably going to see that in a different cohort as well. But typically I would expect to see it maybe in that earlier phase when there's greater uncontrollability and greater of that early muscle inhibition.
Yeah. Okay. So I want to take advantage of your biomechanics background too, if I can. So I don't want it to be all psychologically focused.
Yeah.
So if you could just from a general overview standpoint, maybe tell us if you can, like when we see some of these in these patients that demonstrate learned helplessness, whether if we're defining it through like higher scores on some of these patient-reported outcome measures that we talked about. How does it typically manifest from a biomechanical standpoint? Like, is there one kind of common recurring theme? I'll couch it by saying, obviously, everybody's wired a little different neurologically, psychologically, everybody's inherent problems may be slightly different, but is there kind of a common pattern that we see in patients with high levels of learned helplessness?
Yeah, that's a great question. I think in the literature and the findings kind of that we've proposed, most of the time, individuals that had that greater perceived helplessness really had the common like reductions in knee flexion angle, right? They were landing
Okay.
stiffer. They were, probably because they either had that persistent, quad weakness or the lack of like neural input. And so they weren't really able to eccentrically control their quad right while they're landing.
Yeah.
And so that's, going to, manifest in that stiffer knee strategy. Some of the other things that not necessarily in like a learned helplessness scenario that we've seen, but I would imagine could present similarly would be, in addition to those stiffer knee strategies, having compensations both at the ankle and the hip. And this is, again, very common across like, lower limb loading when you're doing like return to play, sports testing, et cetera, that, the knee might not be asymmetric between limbs, but there's compensations at both the ankle and the hip. But primarily the biggest compensation that I've seen is those reduced, sagittal plane flexion angles, so the stiffer landings.
Yeah. Okay. All right. So, I mean, I was going to try to parse out even further. It's not something where we're not aware of, like peoples with high levels of kinesiophobia tend to demonstrate decreased sagittal knee flexion angles. Okay, we've not gotten that specific yet, correct? I mean,
not with learned helplessness. I mean, obviously, there's a lot of literature that talks about kinesiophobia and reduced knee flexion angles and increased knee abduction moments. Kinesiophobia, fear of re-injury, in and of itself is also related to like joint biomechanics. So I think just building the case for that learned helplessness can also kind of manifest similar outcomes. And I would imagine that because the constructs are kind of like overlaid, that we would see kind of similar findings between, our typical kinesiophobia measures or fear of re-injury or even the readiness to return to sport with those subjective scores of learned helplessness. Some of the other, relative to learned helplessness specifically, might be, actual kinematic strategies. So Susan Sigward has also recently published some articles looking at like underloading of the surgical limb. And so that was really interesting. And she kind of phrased it as like that learned disuse, underuse, because again, these aren't stroke patients. They're not actually, they're able to function. They're able to utilize their limb. But even like 3 months out, they, I think she demonstrated like a 15% reduction in limb loading, right? So they underloaded the limb during a double leg squat, which is something that at 3 months you would expect, someone after ACL to be able to do, appropriately. And so I think that is another, potential compensation that we might see. And I kind of lump the helplessness into the learned non-use kind of phenomenon because they're very similar in the fact that like it's because of these changes in neural input and that uncontrollability that is leading them to for some reason, right, offload their injured limb, even though they have the motor capabilities to load it, right, and to use it.
So again, that's a perfect segue into my next question. And I apologize because I'm probably going to put you on the spot a little bit and make you like take a stance one way or the other. But based on what you just said, kind of those subtle differences in limb loading that may or may not be like appreciable with the naked eye, right, in kind of real time. Do you feel like implementation of force plates and some of that type of equipment is kind of critical standard of care at this point with ACLs? Do you feel like you can still get by without? I asked just because, again, for the, kind of regular private practice owner that may or may not be listening, where there's, financial and budget concerns, obviously, that's a significant consideration. So
yeah, absolutely. I mean, obviously, if it would be great, right, if we could evaluate loading strategies, right, serially throughout recovery. A lot of times I feel like we get, unless we're doing research, we get people around the time that they're going back to sport, right, where we look at, potential, full body kinematics and kinetics. I recognize, like you said, that it's really not feasible, right, for many clinicians to go out and buy either an instrumented treadmill or, a set of force plates.
Right.
I think that a caveat to this, and again, it still costs money, but it's less money, right, is the increased popularity with like wearable sensor technology that
Okay.
we could collect potential loading patterns with that. I've used inertial measurement units on the lower tibia to kind of estimate impact load. And so again, it's not exactly what force plates are looking at, but it could
Yeah.
be a surrogate. And there are a variety, right, of wearable technologies that, some are affordable and some range to like 4,000. So again,
Yeah.
you can kind of tailor it to what you will. Um, as far as like how could we implement this in the clinic without any technology and without any
Yeah.
money, right? I think doing your best to like evaluate bilateral movements, right? So let's just say a double leg squat, right? If you're checking when they're doing a double leg squat, checking for like weight shift throughout like ankle dorsiflexion, looking at, how much ankle dorsiflexion each is getting, you can kind of infer like, okay, are they maybe offloading, this limb? And then any um, you know, looking into like their shin angle, knees over toes kind of deal. Um, I think starting from there might be like the best bet, and then kind of
Yeah.
looking up the kinetic chain, right? Looking at pelvic alignment and lateral trunk flexion from like the posterior view might be another, way again without any equipment to look
Yeah.
at again whether they're loading, symmetrically, and obviously it's not sensitive enough to probably appreciate a true like asymmetrical loading, pattern. But I think it's, if that's all you have, I think that you should at least do that, right?
Sure.
And then if you're
Bare
concerned,
minimum. Yeah.
if you're concerned, I think there are a lot of these like institutes and centers and labs popping up that actually will work to like integrate with sports medicine like clinics to test certain things
Yeah.
like we've done it at UConn where people will send us um, patients to test their strength or to test inhibition. If they're like, hey, this person's not getting better, can you look at their quadricep strength and whether or
Yeah.
not they have some inhibition? And so I think that looking around too and looking to see if you can outsource some of these things if you can't do it in the clinic and you really want or think you have a high risk patient that's at that 3-month mark really still not looking great,
Yeah.
that might be another option too.
Okay. So I'm gonna maybe set you up then for like an endorsement deal or like some sort of check here, but do you have a favorite wearable technology that, again, from a cost effectiveness standpoint for our audience, that you would suggest or recommend?
Yeah. So, offhand, the ones I've used, they were like, I think 3,500 for a pair, which was a lot. I have used recently, and I know that some of the athletic teams actually at UConn use Plantiga, which is like an embedded sensor that can go in the insole of the shoe. So it's like not really
Huh.
invasive. Um, I do think there probably are cheaper, like just IMU options that you could buy that could get you similar, data. The only caveat to that is that it's probably without like the support of a company is going to require like coding experience and data management. And so again,
Yeah.
that doesn't necessarily lend itself to like the everyday, PT
Sure.
practice or AT,
Yeah.
AT high
Unless you have a
school.
sports science degree or
Exactly.
that. Yeah. Right. I got you.
Exactly. So I think there's caveats with that as well. So I don't have a true suggestion on that because I just think it's so variable and it really will depend on the individual's like case use, right, for it.
All right. So no kickbacks coming to you then
No
for,
kickbacks.
from any companies. Okay. So tell me then, if we leave these when they do go unchecked, like in worst case
Sure.
scenario, what do we see? Since you mentioned the cartilage loading, research that you're doing, I
Yep.
figure this is a good segue also. Like, do we see a link with that to post-traumatic osteoarthritis? And what are the kind of long-term ramifications from a joint standpoint and maybe even broader, like just from a functional standpoint?
Yeah, so I think that, you know, typically right after ACL reconstruction, we typically like in that early phase see an underloading, right, of that
Right.
ACL limb. They're not putting weight on it. They're not utilizing it as much as their other limb, whether that's just because of quad weakness or muscle inhibition, whatnot. But there are cases, and I think that Brian Petrosimone has published on this specifically, like a longer term effect. I think it's greater than it was greater than 12 months. They actually saw an overloading of that injured limb. So I think that it's gonna rate like I think it's gonna vary depending on where you are in the rehab process, but basically, and I think it's either right. It's whether we have an underloading early on or whether we have overloading later on, either way, there's an altered loading pattern of this joint, right? So the cartilage of the tibiofemoral joint, the knee joint, right, is going to be negatively affected in some capacity, whether it's not being loaded enough to stimulate, the cartilage synthesis
restoration.
Yeah,
Right.
exactly. Or
Maintenance.
whether it's overloaded, right, and too much cumulative stress is placed on it. And so, I think that absolutely the not identifying these altered strategies is really going to affect our joint health long term. We know that there's data to show that in individuals that have, torn their ACL, that there's altered, synthesis and degradation levels of certain cartilage biomarkers.
Yeah.
And even in people that are, years after, right, ACL injury, it starts that process, that early kind of joint degeneration process, kind of regardless of what we do in rehab, which is unfortunate.
Right. Yeah. Unfortunately. Right. Yeah.
So I definitely think that that's an area where like we want to catch it, or at least try to like mitigate those altered loading strategies, as early as we can, so that they're not kind of developing these learned strategies that they take on with them after they're discharged from physical therapy, or after, they leave a college or whatnot.
Sure.
So I think that's super important.
Yeah. Okay. And correct me if I'm wrong. I mean, it's not just cartilage, but you see bone density changes as well, right? Yes. All right. I did want to drift back because one of the things that actually stood out to me when I heard you speak on one of the ACL study day courses, which were fantastic, and I missed those. So that was a little shout out to Matt Bauman. But was you quoted a depression rate in like post-op, some of the younger post-op ACL patients that was like as high as like 40%, which that was like that grabbed me. I was like, wow, I see it on a day-to-day basis, but when I stopped to think about it, I'm like, wow, is it really that high? I was like, maybe I'm, again, because sometimes I'm not digging down and having maybe the tough conversations, and, a patient presents to you with their brave face in clinic and then may go home, and, it's a little different story when they're behind closed doors with, trusted sources. So tell me, I guess for our audience, if you could tell us a little bit about the depression rate and what you feel like, again, from like a psychological construct, maybe what contributes to some of that in some of these patients.
Yeah. So when I was kind of like developing this learned helplessness theory, like I ended up kind of falling down a rabbit hole of other psychological like constructs, including depression, right? That like we don't necessarily, obviously as physical therapists, as athletic trainers, like we might see the occasional patient that has those depressive symptoms, but generally with active individuals, right, we're not necessarily always thinking that. And I think you just said that, right? You're not necessarily always thinking like, this is what, I'm seeing. And so like I said, I kind of fell down that rabbit hole and ended up looking into that literature of like, well, in these patients, after traumatic injuries like ACL injuries, like what are the depression rates? And so, like you said, they are relatively high, upwards of 42-45%, right, in an ACL population, which is like 4 times greater than like the national average. And part of that, and from the readings that I've done, is that, right, the peak age for ACL injury is like 16. So, between 15 and 25 age group is also an area or an age group that really has common depression symptoms. So it's like it's twofold. And I don't know whether we know which one is which, right? Whether individuals that have depressive symptoms go on to tear their ACL, or people that have a musculoskeletal injury end up having greater depression because it's that age group, right? So I don't think we know which one that is. But I think part of the reason why we might see, and again, I'm not an expert in depression, and if I saw a patient with depression, I would absolutely refer
you will
them
not be on record, I promise. That any psychologists that are listening to the podcast will, will give you a pass.
Yeah. But I think like part of the reason, at least in my thinking, and in some of the literature that I've come across, is that of why like patients after ACL have such high rates is that, one, the recovery process is super long, right? If you say, hey, like Juju Watkins, right? She just tore her ACL. She's out for a year, right? Like you don't even say 6 months anymore. I feel like everyone's like, she's out for a year.
Right.
And so that the psychological impact of such a long recovery, I feel like has to be like devastating, right? I've never had a traumatic joint injury, that knock on wood. And so I think that the length of the recovery in and of itself is devastating. The lack of mobility, right, might also result in that like social isolation and like lowered self-efficacy, loss of self-worth. You think about like if again, an elite athlete tears their ACL, they might have a huge loss of like that athletic identity, right? They're not able to practice, they're not able to do what they love to do. They might not be able to, perform to their pre-injury level. And so I think like those points are really important for specific like groups of individuals undergoing ACL reconstruction who like gain a very strong sense of worth from physical performance, from what they're involved in. And so I think that in general, like depressed patients who might experience kind of greater symptoms of depression might also be like less likely to adhere to, early on rehab protocols. That those are the ones that really count, right? Like we have to emphasize that early phase of like post-op ACL reconstruction and really truly try to reduce those quadriceps deficits, improve muscle inhibition, right? And so that they can already kind of be up higher at a higher level of function as we move through the more functional phases. So I think that could be, part of the reason why we might see it in this group.
Yeah, and like the early rehab, I mean, you want to set them up for success as much as possible, right? To, really ensure they're, especially nowadays. I mean, we're seeing less and less visits allowable, with some of the insurers for their ACL algorithm and that kind of thing. So it's interesting to me, really trying to kind of front load the visits. And then when they get to that strength training phase, I said, sometimes they'll be like, well, we only have this number of visits, so go get a Planet Fitness membership for $10 a month, and here's what you'll do from a strength training standpoint. We'll check in once a week, once every other week, and
yeah, I know that the number of visits is always a point of contention with
yes.
people.
So you've also done, on that note, with treating some of the psychological issues, depression, that kind of thing. You've talked about some remediation strategies, right? You've talked about like using kind of meditation stuff, relaxation, CBT, the general kind of psychologically informed practice stuff, right? Tell us a little bit about implementing those, if you could, and then also, I just alluded to a little bit, but any recommendations for kind of the soft skills aspect of things, like having those difficult conversations with a patient that you think is, kind of heading into like a dangerous place?
Yeah, I mean, so I'll start with the first part. So I think you mentioned like the intervention types. And again, I did mention this before, I think, but Dr. Baez and Dr. Jochimson published a great article on psychologically informed practice. I mean, I'm an AT. I feel like all AT should read that, right? Like whether or not you're dealing with a lot of psychological issues, like it's always great to be able to at least like have an understanding of like what you should be able to recognize as an athletic trainer, as a physical therapist, as any, real sports medicine, clinician. And I do think that they provide some like great recommendations and support for like which specific ones. And again, that was relative to just like, regular sports injury. And, whether that was, improving effective communication, goal setting to enhance like better like self-efficacy, self-talk, graded exposure to certain things. I think that all of those constructs should be absolutely like part of your toolbox. Cognitive behavioral therapies, particularly, right, are those short intervention strategies designed to help modify someone's behavior, right? Like, modify an individual's like thoughts, perceptions, cognition in an effort for them to have some sort of behavior change. And so I think the ones that I've mentioned in a lot of my publications include things that are like really implementable immediately without cost. Obviously, there are ones that cost money, but most of the time you can do things like imagery, guided relaxation, or breathing techniques, like without the use of, apps or, fee for service type deals, which is nice because like in downtime during, whether they're in physical therapy or in the athletic training room, I think that could easily be implemented, right? If you're sitting there and you're like, okay, while you're icing your knee, I want you to think about performing these sport-specific movements like during your recovery. It's not sucking up time, right? It's not taking away from the actual physical like function components, but it's allowing them to kind of work on these psychologically informed practices and those kind of more mental side throughout recovery. And I think a lot of that is neglected sometimes during the actual rehabilitation phase. And I feel like the research is kind of catching up, and we're seeing it, implemented more towards that return to play phase. But I do think that, like any other intervention, if we can get it kind of nipped in the bud earlier, right, or they can start building these practices earlier, that would be helpful. I think one of the other like big things, and I found this with some of my qualitative research, was creating like realistic expectations with patients. Like, I work with an orthopedic surgeon now, and they go through a whole spiel of like what to expect, but then patients still come out of that office and they're like, I don't know what to expect.
Yeah, exactly.
And it's like, and people that kind of don't know, right, go into it almost not blind, but like they go into it with an unsurety or uncertainty, right, of like what's going to happen. And so that actually has been shown to, right, actually cause worse outcomes. So creating those realistic expectations for patients experiencing fear, experiencing psychological like constructs after ACL reconstruction, making sure that as a clinician you're utilizing like goal setting, that can kind of be chunked out into small components so that they're learning versus like a performance level goal, which has been shown to help both with, improved psychological function as well as like learned helplessness behavior specifically. So I think that can help improve some of these outcomes, and something that we could kind of do as clinicians that doesn't take a lot of effort. Again, if we think that someone might need a referral, I think that's another case, but like these things aren't going to hurt someone, right? If you're telling them to practice these things during the treatment or rehab. And so I think that's definitely important to consider. You asked about like soft skills. So I think, as athletic trainers, as physical therapists, like we do have a unique role in these patient lives. We see them so frequently, right? And have such personal interactions with them, right? You're like, oh, I love that patient, I think part of the answer comes down to it, and I don't think we're there yet, but I think part of it comes down to like, can we do kind of preventative screens for these types of like psychologic disorders, right?
Sure.
Using, patient-reported outcomes suggested by previous literature, just kind of screen for some of these things, and whether that's specific to just the joint, whether that's specific to like depression. I think building it into clinical practice would be helpful, because that way, like, again, pre-surgery, if they're already having feelings that kind of mirror depressive symptoms or greater anxiety and greater fear, like those aren't going to go away after you have surgery.
Right? Yeah, right.
So I think starting to implement some of those questionnaires into clinical practice as a way to flag potential patients who might need, further care, I think would be really helpful. And I mean, they do this with like postpartum, right? Females, like I got flagged every time I went to a pediatrician appointment, every time I went to an appointment for myself, they had me do these depression scales. And it's like, great, like just build it in, right? That way, if there's a flag, you can kind of see it. And so I think that's one piece. And again, I think, and I mentioned it already, I think it goes back to like proactively educating people about some of the symptoms and feelings that can arise like following like musculoskeletal injuries. And that it's a long process, and that you're going to have ups and downs, but that this is what to expect. And I think that could be a starting block for improving some of these, feelings.
Yeah. All right. Excellent. So one other concept, I mean, we focus kind of primarily on ACL, but I know you've dabbled in a little bit of other knee pathology stuff, and especially looking at some of these kind of psychological manifestations. Tell us, like, when we look at ACL versus somebody with, I'll say anterior, we'll go with the general umbrella of anterior knee pain or patellofemoral pain syndrome. And obviously it would make sense, like MPFL stuff would probably lump under that same category. Do we see any differences there between some of the different knee pathologies and some of these kind of learned helplessness behaviors?
Yeah, so I mean, as far as like learned helplessness behaviors, I actually, with one of my colleagues at UConn, Dr. Neil Glaviano, he studies patellofemoral pain a lot, and we've talked about, whether or not learned helplessness might be present in people with chronic patellofemoral pain, right? Because learned helplessness has been demonstrated in other chronic pain populations like TMJ. And so like the thought is like, oh, okay, well, maybe this is another kind of different avenue for the development of learned helplessness, not necessarily neural, but maybe it's more of the chronic pain changes that can, that cause it, versus like the actual insult to the joint injury. And so that I think we're still kind of fleshing out. We don't know that. And so we do have some current projects that are going to kind of look at the difference between ACL populations versus patellofemoral pain relative to the neural side, as well as some of the psychologically, mediated constructs. I think relative to like fear of re-injury, fear avoidance beliefs, one of the studies that we had done demonstrated that individuals actually with anterior knee pain had greater fear avoidance compared to the ACL. But the reasoning, like why, is still kind of unsure.
Still unclear. Yeah. Okay.
But I do think that this is an area, right? Like I feel like ACL ends up being like, it's studied a ton, right? And then other joint pathologies kind of like trickle down after, right? So I did some work in MPFL looking at kind of functional outcomes, and whether there were like symmetric loading during functional movements, like I think it was 6 months after MPFL, and there were still very large like asymmetries in loading, asymmetries in patellofemoral like contact pressures. So I think that what's going to happen is that you're going to see an increase in some of these publications and research, and therefore clinical recommendations on how to manage and deal with kind of MPFL injuries, anterior knee pain, where we're going to start to see more of the research that's historically been done in the ACL population kind of trickle down and now being done in these other like joint pathologies, which I think is needed, and I think that'll be cool. But I do think it tends to happen in that bulk of ACL literature first, and then trickle down. And so that's a hope for he and I to kind of work on that and see if there's differences between those two populations.
Yeah. And logically, to me, it would make sense that, as opposed to ACL, which is like a one-time traumatic injury, right? Somebody that's been like a multiple time dislocator or that kind of thing, with MPFL injuries or sublux, multiple times, might actually be worse on that fear of apprehension.
Even if you think about like shoulder dislocations, like I'm sure that, you could apply it to almost any population that's going to experience that type of, traumatic injury, subsequent episodes, uncontrollability. Obviously with like the neural piece, we know that people with ankle instability have similar like neural profiles, especially those in chronic ankle instability. So I do think that there's a lot of area for like future expansion in this area. Absolutely.
All right. So you alluded to it briefly here. I wanted to kind of pick your, because I could probably pick your brain all day, but we both have paying jobs, I'm sure, that we have to get back to. So tell us a little bit about your kind of ongoing projects, like what's next for you in the future and coming up here in 2025 and beyond here.
Yeah. I have a lot. So in my role as a director of research for ISM, or the Institute for Sports Medicine, I have a lot of different roles that differ from, my specific like dissertation work, or if you will, like my like primary like love of research. But some of the studies that I have that are directly related to like what I love, I have a funded study that's looking at structural changes in the brain and its relationship to learned helplessness, actually. So, in some of my earlier work, I did like, we looked at the association, but like it's self-reported helplessness. So we're looking at like whether we see structural changes in the brain and whether or not that's related to subjective helplessness in a population of ACL, healthy, and PFP. So we're kind of trying to bridge that to see whether, we see anything there. So I'm really excited about that one. We just started collecting, which has been a long time coming. So that's one. I think that some of the other things that I have ongoing include trying to, there's a couple that we have with our students that are exciting, and they kind of go back to, I did a study with women's basketball a couple of years ago where we looked at impact loading and its relationships to like cartilage health and injury. And so we're doing another study looking at impact loading, but in hockey athletes. And so we'll use embedded sensors to kind of look at I don't want to say performance, but performance metrics, impact loading in hockey athletes, which will be fun. No one's ever really looked at that. So our student is a hockey fan, so it's very in line with her interests.
Sure, passionate.
She was a Division I athlete, so she's
Okay.
very driven with hockey, which will be fun. And then some of our other ones that like we're undertaking as part of like the institute include like implementing a clinical pathways like model so that people within our orthopedic network, if you will, like if they have ACL, MPFL, whomever, we kind of are going to start to develop these clinical pathways so that at pre-surgery, we're going to say, hey, this is what you should be doing, right, for your patients relative to like functional testing. And we can offer those services. Same thing at 3 months, same thing at 6 months. Because a lot of, I talked to a lot of the orthopedic surgeons here and they're like, we just don't have the bandwidth to, measure strength and measure biomechanics, but we want that data, right? And so to implement that, I think would be hugely beneficial to everyone in the area.
For sure,
And then lastly, we have a potential study looking at like the predictive modeling capabilities using like EMG during a strength, peak torque assessment, pre-surgery, and whether or not like with the use of AI, we can do some predictive modeling to, potentially identify who might go on to, develop arthrogenic muscle inhibition or that AMI. Again, this is very preliminary in the works. We have a fantastic medical fellow who's been kind of pushing this along, but he was talking to me about this and I was like, I think that's great. So there's a lot of things in the work, but there's always more potential, but those are the big things that we're excited about.
Cool. Sounds great. So tell us, one question I always like to kind of throw out to people is like, outside of your main research interest, is there any other topic or concept that you're hoping to learn more about specifically in 2025 here?
Yeah, so I mean, I think one of my colleagues, Dr. Kristen Morgan, she's a biomedical engineer. She works at UConn. She does, and now it's still ACL, but she does a lot of asymmetric loading. And using that as an intervention strategy to actually reduce interlimb asymmetries during loading. And so I'd love to learn more about how she kind of programs that intervention so that, if there are applications for, other populations that we could kind of like build off that. As far as, I would love to learn to code. I really would. I just don't have the bandwidth.
Yeah.
But I think that's just such a huge area. I mean, AI is always like a big topic of discussion now. And so I think leveraging that, especially for like injury prediction models or things like that, would be super interesting and beneficial to a lot of different groups. So if I could, do that, that'd be awesome.
Yeah. Well, since you're representing UConn there today, since you're repping them with the sweatshirt, I have to ask. Dan Hurley in the news a lot this week or last week. Is he as crazy in person as he is on the sideline? Because the reason I asked is he was at URI previously. We have a coworker who swore he was the most chill guy. I used to run into him and have conversations in the gym, and then obviously the sideline persona was a little different. So
I have never met him personally.
Okay.
I have heard. So I'm assuming he's a very nice guy.
Yes.
He's a great coach. He's intense, definitely intense. Yes. I have heard though. So I work in Gamble Pavilion primarily, and there's so when the men practice there very frequently. My office is in the basement, but they have a concourse that you can like walk around. And generally in the cold, I walk around. Sure. I have not been yelled at, but I have heard that if you walk on the concourse during practice, he tells you to get out of the room.
Got it. Okay. Understood.
So I think most people try to avoid walking during the men's practice. But I haven't met him personally, so I can't speak to him personally. But
we won't get you on record or anything.
No, you or anything. But I'm glad that he took UConn to 2 national championships.
Yes, I was gonna say March is always a good time to be at UConn, right?
Exactly.
So tell us again any hobbies or you mentioned coding. any other hobbies or interests that we wouldn't find on your bio or the
Yeah.
the web page? Any personal interests?
Yeah, I mean, I was trying to think about that the other day. I said to my husband, I was like, what are my hobbies? I don't know.
Yeah.
No, I mean, I love craft. I've always loved crafting. I
Okay.
haven't had time to do it lately just because of kids and
Yes.
work, but I love crafts. During the summer, I love going to the beach and I love sailing. So I'm hoping to teach my 4-year-old I'm hoping to take him sailing this summer,
Yes.
on our little sunfish. But yeah, it's really, right now it's really just kind of hanging out with the family, with my kids. My parents live close, and so kind of, hanging out with the family
Yeah.
has been fun.
Awesome. And what's the Connecticut beach of choice?
My parents have a small cottage in Old Saybrook, so we end up
Okay.
just going there.
Gotcha.
If I had to go to a public beach, I haven't been to a public beach in a long time.
Yeah, well,
Yeah, my
Connecticut not really renowned for the beaches, right? So
Yeah,
yeah.
my husband's from Madison, so we've gone to Hammonasset, but honestly, during the summer, like I avoid the beaches because they're so
Sure.
busy.
Yeah.
So I'd say probably a Rhode Island beach,
There you
honestly.
go. All right. Fair enough.
Yeah.
All right. Well, this has been awesome. Thank you very much
Yeah, thank
for
you.
all your time, and especially since I just kind of cold called you out of the blue and you agreed to it. So I
Never
really
a
appreciate
problem.
you taking the time out of your day and sharing some of your insights. This has been great.
Great. Well, I enjoyed talking as well.
All right. Thanks,
All right.
everyone. Take care.
Take care. Bye.
All right. See ya.